All right, everyone. Thank you so much for joining us today. This is part 2 of a 2-part series where we are discussing the AUA S2O guideline on upper tract urothelial carcinoma. My name is Erin Kirkby, and I'm the Director of Guideline Development. I'm joined today by 3 of our panelists from the UTUC guideline. We want to make this as interactive as possible, so I do want to encourage everyone to please take advantage of the chat feature so that we can have our panelists go ahead and answer your questions on how to implement the guideline into your practice and give us a bit more insight into the development of the UTUC guideline. With that, I would like to hand it over to our panelists to introduce themselves, as well as to provide some disclosures. And I'll start with the chair of the UTUC guideline, Dr. Jonathan Coleman.
Thanks, Erin, and thanks for the invitation. My name is Jonathan Coleman. I work at Memorial Sloan Kettering in New York City, and I was pleased to be able to chair this guideline with a group of phenomenal experts in the field. 2 of them are here with us today, Sarah and Phil. Hopefully we'll have a great conversation today. I have no disclosures. As being the chair of the guideline, I can have no conflicts as far as anything regarding any industry associations or any conflicts of interest.
Thank you, Dr. Coleman. Next, I'd like to go to Dr. Suka.
Hi, everyone. My name is Sarah Sutka. I'm at the University of Washington in the Fred Hutchinson Cancer Center. It's a real pleasure to be here today, and it was an absolute honor to serve on this panel. So I'm excited for our conversation. I have no relevant disclosures for upper tract urothelial carcinoma. I am running a Janssen clinical trial in bladder cancer and serve on a medical steering committee for them as an advisor.
Go ahead, Dr. Parazio.
Phil Parazio at the University of Pennsylvania in Philadelphia. I was a site principal investigator on the Olympus trial for the UroGen product, and that is my only disclosure.
Great. Thank you so much. And once again, I want to remind our attendees that we encourage you to use the chat function in order to ask any questions of our panelists as we begin with our discussion. So before we get into the meat of the guideline, Dr. Coleman, I was wondering if you could give us a brief overview of UTUC. Oftentimes we hear that it's very analogous to bladder cancer. Often in previous years, many of the clinical decisions were made based on bladder cancer patients. So I'm wondering if you can give us an overview of some of the differences between the 2 diseases and how some of those differences have shaped how we can better treat UTUC patients today.
Yeah, thanks, Erin. I'll try and be brief because there are a lot of differences, but the main ones I would say is that genomically, the landscape of upper tract cancer is similar to bladder cancer. However, the mutations that we find in upper tract are of different frequency. So we find a lot more FGFR3 mutations in upper tract cancer. Importantly, we find a lot more high grade in upper tract cancer than we find in the bladder. Bladder cancer is predominantly low grade tumors for most patients, whereas in upper tract, it's over 65% are high grade. I think another major difference, too, is that in the treatment of upper tract cancer, we're also dealing with kidney function as a main outcome or a main endpoint that we're worried about because the main treatment options that we have are nephroureterectomy to remove the patient's kidney. So that definitely flavors a lot of what we have to think about when it comes to managing upper tract disease, and that's renal functional outcomes. And then importantly, things like Lynch syndrome. So hereditary factors play a major role in upper tract disease. And in fact, when you see a patient who has upper tract cancer, there's roughly about a 15% chance that patient has Lynch syndrome or some hereditary form of disease, which is promoting tumor in the upper tract. So that means that patients are at risk for contralateral disease in the kidney. It also means that there are some strategies that you have to think about as far as handling those patients. Looking at other risks for other cancers, such as colorectal cancers, gastric cancers, and so forth, screening those patients, and even a potential impact on those patients' family members as well if they screen positive for those diseases. So upper tract is a very nuanced disease and something that I think people need to be very aware of in terms of some of the aspects of managing these cancers.
Thank you so much, Dr. Coleman. Dr. Suka, I'm wondering if you could please give us sort of a brief overview of some warning signs for UTUC, and then sort of discuss kind of an initial workup of a patient who is brought in with a potential UTUC and what that might look like.
Sure. Thank you so much, Erin. So I think, classically with any urothelial carcinoma, we worry about gross hematuria in the absence of infection or another clear causal sort of a source being a primary way that a lot of these patients present to either their primary care practice or they get referred into urology for evaluation. The classic other features, though, because we're talking about tumors that can obstruct the upper tracts that we might also see patients who are presenting with an acute renal injury or a change in their renal function that's unexplained. They might have, if it's a relatively acute obstruction, although that's relatively uncommon here because these tend to grow over time, they may have flank pain or hydronephrosis that's identified sort of incidentally on imaging that's obtained for some other evaluation. I think in terms of the baseline evaluation, when patients are being worked up with a high suspicion of upper tract urothelial carcinoma, we're talking about a cystoscopy in the clinic, a urine cytology, and then upper tract imaging. We generally start with cross-sectional imaging if patients are able to receive a CT scan with contrast, iodinated contrast. The critical component is a multi-phase CT scan with delayed imaging to evaluate the inner aspect of the upper tract of the urothelium. We did specify in the guidelines that patients who can't get iodinated contrast or have other contraindications to CT, we can do MR urography. And then for patients who can't get contrast, you can do non-contrast cross-sectional imaging and then retrograde pylography to evaluate the inside of the upper tracts and try to look for filling defects and masses. But of course, staging is really critical. And then to make sure that you sort of understand making sure that we characterize the volume of tumors is a big part of what we got into here in terms of the risk stratification. So understanding the extent of the disease is really critical.
Dr. Parazio, could you expand a bit more on what we talk about in terms of risk stratification within the guideline?
Yeah, I think it's one of the most important pieces of this new guideline. And I think it's one of the most valuable pieces. And I'll tell you, the group, just as an anecdote, spent a lot of time kind of trying to figure out what the correct risk stratification was and what that means. And so I think it has to start with the definition. What are we risk stratifying for? And we decided as a group to use the literature and be as objective as possible. So this is really risk stratification for muscle invasive or invasive upper tract urothelial cancers. And so the main components of that risk stratification are grade, either by urine cytology or mostly by biopsy. We really advocate that almost every patient with an upper tract tumor should have a diagnostic ureteroscopy and biopsy of a mass to look for a low grade versus high grade tumor. And then obviously we're looking for other components that we all know. Is there hydronephrosis? Is there any evidence of invasion on the imaging that could, be indicative of locally advanced stage, enlarged lymph nodes? And what does it look like on your ureteroscopy? Is it papillary? Is it sessile, meaning is it flat or spreading? And so these are all things that kind of play into that risk stratification scheme that help us decide what the best way to treat patients are.
Now, one of the things that the guideline did talk about was the lack of comparative effectiveness data across various clinical situations when discussing endoscopy with tissue sampling. So I'm curious if, and I'll open this to any members of the panel, if you could comment on any insights that could influence the decision to use any of the various approaches over another.
One of the biggest challenges, and we started talking about sort of the differences between upper tract and bladder. One of the hardest sort of diagnostic dilemmas that comes with upper tract urothelial carcinoma is actually being able to get the diagnosis. A lot of times these tumors can be very hard to biopsy, and we're limited by the equipment we have, right? Because we are using thin ureteroscopy with biopsy forceps that are often fairly challenging to manipulate. Some of these tumors, especially if they're in the mid-ureter, can be just hard to sample based on location and sort of the limits of our tools. So some of it is we have to use what we have available to us, and sometimes have to be somewhat creative. There's a lot of these tumors can be challenging to get adequate biopsies that your pathologist can look for and give you an accurate grading. I think there also is some heterogeneity in these tumors, and so you may have predominantly low grade with some components of high grade. So we're really taking into account sort of the scope of your evaluation of the patient that you get from not only direct visualization and hopefully cytologic sampling, whether it's with a small biopsy, a brush biopsy, cytology and local barbotage. There are certainly, if there is concern radiographically for metastatic or nodal disease, sometimes sampling the node can be very helpful, I think. And then we certainly use that to sort of guide more advanced treatment for those patients who clearly look like they have more advanced disease. But there are patients also in whom you can't necessarily do a ureteroscopy. So we talked about sort of the fact that we advocate against aggressive dilation to get into the upper tract if it's really challenging to do, because we don't want to perforate the ureter and risk tumor spillage. We have to adhere to oncologic procedures here. So we talk about, passive dilation when necessary to facilitate endoscopic evaluation of the upper tract and safe biopsy. But I think that that's actually one of the sort of the diagnostic dilemmas or the challenges with upper tract is getting a decent sample. And sometimes you have to be a little bit careful, and also sort of thoughtful about how you obtain that.
We all do this similarly, but a little bit differently. Sarah, since you answered so nicely, I'll ask John first. When you're teaching the residents or the fellows, John, what are some of the basics of upper tract endoscopy for UTUC that you do? And then I'm happy to talk about it too. I just did a case today and we were literally talking about this a few hours ago. So
yeah, I think it gets back to a little bit of what Sarah was talking about earlier, and that's the initial evaluation of patients' upper tract disease. So as I mentioned, the nuances of treatment are such that you're trying to understand things like, where is the cancer in the upper tract? What parts are involved? Because, is this patient going to need, say, a distal uterectomy versus a nephroureterectomy? So you need to know what parts of the urinary tract involved, where the cancer might be, where the higher grade cancer might be, and also being able to sample multiple different areas inside the upper tract, because there can be sampling errors. You may biopsy the piece of tissue that's the easiest one to reach, but that may even be the lowest grade one, whereas high grade cancers can be somewhere else. So I always tell them, try and use sort of a no-touch technique when you first start off. So you want to look inside and you want to take a very systematic approach to evaluating the upper tract. So I try and go in with a flexible ureteroscope into the upper tract without any guide wire if I can. And if I can't, I'll actually use a glide wire. So I use a glide to get in, and I only introduce it into the very distal part of the ureter, just a very small amount. I'll flip the scope over, get the scope to go in, and as soon as that happens, I get the glide wire out. And then I start mapping my way up the ureter to say, like, where are the tumors? How many are here? What do they look like? Is it the lower third? If the tumor stops at a certain level, then I'll take an image, right there and say, this is where the scope was when I saw the last tumor. And then that way I kind of have that graphically there. And then I'll march my way up the ureter. If I see more tumors, I'll try and kind of annotate those. I don't do a retrograde right away because I'm looking in the ureter with my scope. And if I do a retrograde, that may mess up my cytologies, because putting contrast material in can give you a false atypia or something like that on a cytology. So I typically will withhold doing cytology or doing a retrograde until I've actually gotten the scope into the ureter and I kind of have a sense for what's going on, because I am putting the scope in. So I'm going to be looking. And the scopes today are much more flexible and easier to use, I think, than the scopes of old, which were bigger and more difficult, and you'd be more worried about, safety wires and things like that. I don't use a ureteral access sheath. I won't dilate the ureter, because if I can't get in, I don't want to rupture something and take a simple problem and make it into a complex one. And then to your point about biopsying, Phil, what I'll do is I'll use a cup biopsy. And when we typically do biopsies in the bladder, we're used to grabbing a piece of tissue and pulling back. And that's that jerking motion to kind of rip it off that we do. And that's how we get a good piece of tissue. What I'll actually do is two things. Number one, I'll remove the cap off the ureteroscope. I don't like to have that little squeegee cap on there. I want to just be able to put the device in without having anything that's going to pull the specimen off when I come out. Or if I do have the squeegee cap thing on there, the sealer, I'll actually spin that off as I'm pulling out my device if I need to use it, because I don't want it to pull the specimen through it. But I'll go up and I'll grab I use a piranha. I don't use a big OPSI, basket, because I don't like the backloading that you have to do through an access sheath. But I'll go up with a piranha and I'll grab the tissue and then I'll push it forward and I'll pull it off that way, because as you push it forward, it'll kind of, tear off a specimen a little bit bigger. You'll be surprised at the size of specimens you get. And then I'll pull that back out and I'll actually pass it a minimum of 3 times to get 3 samples off of a tumor. And I'll try and go for areas that look the most high grade. If I see like a papillary tumor over here and a more sessile one over here, I'm going to go for the sessile tumor and try and get that one done. And then I always do my washings, my cytologies, I do at the end after I've done my biopsies. And I think that's because, and we've shown in some data that we published, that you're going to have a better cytology yield if you do your cytologies after your biopsy, because you'll have more cells floating around. And that's important because you may get a biopsy that comes back as low grade, and the biopsy is, and everyone has good pathologists. They'll say this is low-grade cancer, but then your cytology comes back as high-grade. And that means that you sampled the low-grade part, you maybe missed a high-grade part, but that means there's high-grade cancer hiding in there somewhere, and that's going to change the prognosis for that patient. It's going to change your management strategy for that patient. And so that's how I approach it. And then I'll do a retrograde at the end just to get a good mapping of kind of what's there. And also just to make sure that I like to see the contrast come out of the kidney at the end of the case, that it's draining and I can see that it comes out. And in those cases, I might not leave a stent, but if there's any concern or any question, I'll leave a stent to my patients afterwards.
Thanks, John. Yeah, just a couple of contrasting points. I do like ureteral access sheaths when I'm not worried about a ureteral tumor or stricture or something tight, for a couple of reasons. I think it just facilitates access for big biopsies, getting bigger tissue samples out. So I do like that. And in some ways it kind of isolates or insulates the bladder. So if you are getting tumor cells, they're coming right out that sheath and out of the urethra rather than settling in the bladder. And I agree with you. I tend to be pretty frugal in most cases, except in upper tract urothelial cancer. And I tell the residents and fellows all the time, the diagnosis here is so important. It's going to change so many things for this patient. Spend the money, get the tissue. I do like a piranha. I also use a Segura basket, which is kind of a stiff basket when you've got a big papillary tumor on a stalk, and do the same thing you do. You push it forward, and Serena-Mateen kind of actually published on that, where you can kind of snap off a good papillary chunk of tumor and bring that whole thing back as you bring the scope out of the sheath. So that's one of the tips and tricks, and I do. And the only thing I do differently, and I can't really explain this one with cytology, I do a cytology at the beginning, or when you get up there and you're looking right at the tumor. I feel like you get a real pure cytology there. And then after we biopsy later or whatever we're doing, get another wash when we've kind of barbitaged everything around. And I'll use both of those.
I do the same thing. And I think the basket actually can be really, really helpful, especially with papillary tissues. I don't use the big biopsy either because I just don't like the backloading, and I worry about traumatizing the ureter. And I don't personally use ureteral access sheaths, but I think that the piranha, unfortunately, you oftentimes get these very tiny biopsies that your pathologist may struggle with. So I think, critical things that I have ready, I've got a little jar that's got just a couple drops of saline. And then I do think it's really critical to not pull your piranha through the seal at the back of the ureteroscope, because you'll lose a ton of tissue that way. I think it's really what Jonathan talked about is sort of a critical kind of technique to just have that be loose, so you're not ripping the specimen off. And then the basket is a great way to get good specimen, I think, especially when you have a more papillary tumor. The hardest ones to sample, though, are the sort of really kind of sessile, infiltrative mid-ureteral tumors. Those are the ones that I think that we all struggle with, just because they oftentimes, it's just, you may not have great things to take bites of, and you're sort of taking, you can't really necessarily angle your ureter. And so you've got to be thoughtful about how you do that. I think brush biopsies can be really helpful there. And then thoughtful approaches to barbitage and not messing up your cytology by putting in the contrast if you don't need it.
We've talked about ureteroscopy. What's the frequency of discovering a bladder tumor while you are any sort of lower tract tumor while you are, looking for upper tract, and how exactly would that change your management approach?
This is actually an area that we struggled on a little bit in the group. I'm just going to say this one point, and I'll pass it off to Phil or Sarah or something. But it's a question of when you see a tumor in the bladder and upper tract disease, which one do you handle first? And we really couldn't decide, one way or the other, because everyone was very different about how they approach that. There's many different reasons for, doing the bladder first and then doing the upper tract, or the upper tract first and then the bladder. And I think it really is very situation dependent. But I would say it's very common, right? So upper tract cancers do spread to the bladder very commonly. 60% of upper tract cancers will end up seeding into the bladder in patients during long-term follow-up. And there are some different, markers that predict for that. And then, lower tract tumors can also get into the upper tract, and many times they'll end up in the, patients with bladder cancer will end up forming upper tract tumors. And many times that's lower third ureteral tumors. I'll let maybe Phil or Sarah want to talk a little bit about some of the strategies that are used to minimize the seeding that can occur from upper tract to bladder.
Yeah, happy to talk a little bit about it. And, I think we've all seen people who've had their entire disease course changed by seeding in the bladder, or by progression of upper tract disease into bladder cancer and vice versa. So a couple little things. First is I really try to avoid stents whenever possible, unless I think the ureter is injured or it's a solitary kidney and I'm worried about drainage. I very rarely leave stents. And I tell patients often, I'm going to err on the side of not leaving a stent. You might not like me for a couple of days. You may have some flank pain. You may have a little bit of discomfort there, but I'm not going to leave you in an area that you're going to get sick. We don't want to have an obstructed pyelonephritis. But I think that really does minimize a fair amount of bladder seeding. And I think there's growing evidence to support that practice. And I think the other one where there is evidence, it's not even growing, it's there, is for intravesical chemotherapy. And so anytime I see a tumor in the urinary tract and it's instrumented, that patient gets intravesical gemcitabine unless they have a contraindication.
Agree completely. And I think the one other thing that we did say in this set of guidelines, though, is that you should treat the lower tract tumor at the same time as the upper tract. You don't have to bring them back for a separate operation. These patients don't need more anesthesia than they're already going to be getting to manage these upper tract tumors. So if you find synchronous lower tract tumors, I think we did have some sort of debate about whether you take care of the bladder tumor first or the upper tract tumor first. I think that's going to be, again, as Jonathan said, situation dependent, but definitely you can handle them in the same operation. And I think that the adjuvant chemo is a critical piece. And I also strongly avoid stents if and when it ever possible. And if I have to stent an upper tract after doing a biopsy because I am worried about them obstructing or something like that, it's on a dangle and it's only for a couple of days and I get it out right away, have it out within a few days just to make sure that patient doesn't have a renal failure issue or episode. But I think those are critical points.
Yeah, and I'd say the bladder cancer, how you handle the bladder cancer, just that's according to the other AUA guideline, which is bladder cancer guidelines. So track that guideline in terms of what to do with bladder cancer. Just quickly, some of the reasons or rationales for one versus the other. So some people like to do the bladder first to get that out of the way, so that way. The concern is if you do the upper tract first and you end up leaving a stent in the upper tract, and then you go down to do the bladder, you could be, transmitting some pressure from the bladder up into the upper tract, into the renal pelvis, just from the in and out washing of your scope. Or if you use continuous flow, then you could, be overpressuring the upper tract through a stent. So some people don't like that. Also, if you end up going up in the upper tract and there's no cancer there, then you're back in the bladder and then you're washing cells up in the upper tract potentially afterwards. That's a risk. Other people felt like, no, you should really, handle the upper tract first. Get that out of the way, make sure you're cleaned everything out of the upper tract and wash everything out. Then you do the bladder, then you can wash the bladder out at the end, and then you can minimize, the effective tumor coming down into the bladder afterwards. So there were kind of like a lot of back and forth on that. And we finally just settled on, situation dependent, whatever, if there's a big bulky bladder cancer, maybe you don't want to deal with that, just deal with the upper tract and answer your other questions later. But there's rationale for one versus the other in terms of why some people do one versus the other.
So now I'd like to transition us to talking more specific management of disease. So I'm wondering if we could talk about if you're in, once you have the risk stratification, in terms of stratifying a patient as low versus high risk, as well as favorable versus unfavorable disease. Can you comment on what exactly are we going to be discussing with the patient in terms of management options here?
Sure. Thank you. So I think, this was actually, again, as Phil mentioned, this was one of the kind of critical things that we spent a lot of time on. We thought it was really important, as with all of our malignancies, to give a kind of a reproducible risk stratification schema so that these patients can get risk adapted therapy and then also surveillance. But obviously, the critical decision making is when you have someone who's low risk versus high risk is, first of all, whether or not we can consider an organ sparing approach, which is especially important when we're talking about the treatment being nephroureterectomy for these higher risk and invasive tumors. It's also important in terms of how it guides our sort of other adjuvant therapies. So for low risk tumors, generally, we're going to be favoring organ sparing approaches if and when possible. That will be guided to some degree by the volume of disease and whether it's feasible to primarily ablate the cancers as opposed to resecting them. So with either segmental ureterectomy or nephroureterectomy. In terms of ablation strategies, we especially are going to be thinking of that's going to be guided just like it is in the bladder, whether we're choosing sort of obviously laser as sort of the primary treatment, I think, is what most people end up using, but there are some patients in whom the volume of disease makes that challenging. And so we think about using an intra luminal ablative agent like the Jelmyto product, and there's certainly other treatments that are other clinical trials that are being where other investigational agents under development, trying to see if we can do a better job of ablating tumors and sparing the organ. For patients who have CIS or bilateral disease, we certainly do think about induction intraluminal therapy, whether it's BCG that's refluxed up or delivered in an antegrade fashion through a pre-placed percutaneous nephrostomy tube. For the higher risk disease, for the invasive disease, though, we are talking about resection. And so that, again, based on that first mapping study we did where we looked at where the tumors are, we're talking about whether or not we have if it's a distal ureteral tumor, we can do a distal ureterectomy with reconstruction of the urinary tract. That's obviously preferable. If it is kind of pan-ureteral disease or upper tract tumors where we don't have the ability to segmentally resect them, we're talking about nephroureterectomy. And then based on the high grade and high risk features, nodal involvement, invasiveness, we may be getting into discussions about preoperative chemotherapy, so systemic chemotherapy, which we also comment on, as well as adjuvant immunotherapy, and that's based on the final staging. But obviously, we're talking about like the spectrum of treatment of the entire disease. So the most important thing is to accurately risk stratify the patients at the beginning, so that you're not either undertreating or overtreating the patients, and that your surveillance is similarly appropriately risk adapted.
The important part that Sarah was just making there is about, now that neoadjuvant chemotherapy has become a more standard of care approach to patients with upper tract disease in the high grade setting, many people have sort of raised this question of, are we risking over treating some of these patients? And the risk strata that we put together in the guideline was really meant to really identify and clearly define a group of patients that are really, T2 high grade upper tract that really should be looked at for neoadjuvant therapies and neoadjuvant options. There's also kind of a high risk or high risk favorable group where, there may not necessarily need to be such aggressive options taken, even including, potential endoscopic approaches. And then we also really wanted to define a group of patients that fell on the low risk spectrum where we could say, these are really patients that you can start thinking about, kidney sparing options and with endoscopic approaches. And so we really tried to tie these risk stratification, criteria, these different categories, to really different management approaches that can be used in those patients, kidney sparing approaches, and then those patients who have much more aggressive cancers that really should be strongly considered for neoadjuvant chemotherapy options. Because an important point that got brought up over and over again is that this is a highly lethal disease. It's a very, very aggressive cancer. Patients with high-grade upper tract cancer, keep in mind that just that diagnosis of high-grade upper tract disease is associated with a 50% 5-year mortality rate, historically, for patients who didn't receive neoadjuvant chemo with just standard approaches. That's the best therapy we could get, the best outcomes we could get for high-grade cancer. 10 years ago, 15 years ago, it was a 50% 5-year mortality rate. That's pretty bad. And so now we have to think about defining that group, the really high risk patients, based on clinical criteria. But then we also have to be careful to also understand that there is, a less aggressive, more favorable risk category, and then stratifying those based on the risk features that we talked about before.
Yeah, I'll just make one other quick adjunctive point that kudos to the scientific team who really pulled the data and helped us put this all together. And what I'll say that's not entirely clear is that at the bookends of this, the data is really tight in that low risk favorable group. Those are patients who are not going to die of upper tract urothelial cancer. You can try ablative techniques. You can try a variety of things to keep kidney around for them. And on the flip side, the data is pretty strong about that high risk unfavorable group, that those are patients with very likely systemic disease, whether it's truly metastatic or micrometastatic. And these are the people we want to throw everything we have at. So the data gets tighter out there. And certainly there's a gray zone in everything we do. But I think we really try to delineate that nicely for everybody who manages this disease.
Yeah, and to that point, especially for that really high risk group. So we not only brought in the discussion of the importance of considering neoadjuvant chemotherapy, especially given that cisplatin is kind of the cornerstone of the neoadjuvant chemo in these patients. So ideally, we want to give it to patients who have as much renal reserve as possible before they potentially are losing a kidney and might lose their ability to receive cisplatin. We also talked about lymph node dissection, and then we talked about a number of sort of critical components of the technical operation to make sure that you've adequately eradicated the disease, including how we handle the bladder cuff and close the bladder, and the importance of perioperative adjuvant intravesical chemotherapy as well. Because again, we're also trying to avoid downstream seeding. So I think that we certainly tried to provide kind of the whole spectrum of therapy, but it's honed on this risk stratification. So that's why the risk stratification and adequate staging is so critical.
So one thing that we've now introduced into the conversation is chemotherapy. So Dr. Parazio, I'd like to turn to you first. If you could comment on just the administration of chemotherapy in terms of timing, technique, things like that.
Sure. Yeah, and we'll focus this part on systemic chemotherapy. I mean, we talked a little bit about intravesical chemotherapies and how to use that. But I think we all recognize in that high-risk unfavorable group, there's a significant proportion of patients who will have muscle invasive or at least T2 or greater disease. And there's a real rationale to use systemic chemotherapy in the perioperative setting. And I'll leave it at perioperative for the moment. The first is there's level 1 evidence. There's randomized trial of adjuvant chemotherapy that shows a survival benefit for patients with high-grade invasive upper tract urothelial cancer. That's the POUT trial. But there's a lot of other data that points us to this is a valuable practice. First of all, we know neoadjuvant chemotherapy, if we think about it the other way, works in bladder cancer. And John mentioned some of the similarities between the diseases. We know platinum-based chemotherapy is effective for this disease. We know we're often talking about radical nephroureterectomy and decreasing GFR. And we know that decreasing GFR can preclude platinum-based chemotherapy after surgery for a significant proportion of patients. Also, keeping 2 kidneys around lowers the toxicity profile for patients when they're getting platinum-based chemotherapy. And there's now growing data in the neoadjuvant setting. So we really think it's important to have this conversation with patients that systemic chemotherapy is part of the treatment for high-risk unfavorable upper tract urothelial cancer. If we think that if they've got 2 healthy kidneys and they're a robust patient and we're pretty sure they're going to be able to get chemotherapy after surgery, yeah, it's okay to bring that patient to the operating room, do a radical nephroureterectomy, get a good pathologic analysis, and then if they've got T2, T3 disease or node-positive disease, put them on an adjuvant protocol. But in the patient who's got that borderline GFR, they're hanging out in a 45, 50, 60 range. If you take out a kidney, you're going to drop them out of the realm of getting platinum-based chemotherapy. Or in patients who've got big, bulky tumors, whether you use Dose-10-Zemvac or Gemcis up front, you'll see debulking or decreases in tumor size. You'll see surgery potentially get a little bit easier. And we hope long-term we see survival benefits with it. So that's the kind of brief conversation I have with people now based on, once again, data and the guidelines.
Yeah, and just the one aspect I would add into that too is that if you look at adjuvant versus neoadjuvant, you're much more likely to be able to get a full course of therapy into patients in the neoadjuvant setting. So if you want to get 3 to 4 courses of therapy into your patients, which is effective chemotherapy, you're much more likely, and we've seen that in all the neoadjuvant trials that have been published. In the adjuvant setting, including the POUT trial, it was very difficult to get even 3 rounds of chemotherapy into patients. So a lot of patients received substandard chemotherapy in the adjuvant setting because they just, as Phil pointed out, they just couldn't tolerate, a full, 6 or full 4 courses of chemo, or even 3 courses of chemo. So that's another, aspect in terms of why the neoadjuvant approach might be a better way for patients.
And with the neoadjuvant approach, we know from data from phase 2 trials that with cisplatin-based chemotherapy, we can get somewhere between a 15 and 20% YPT0 rate, which those are the patients who are most likely to have a durable long-term disease-free survival. So ideally, if we can get them adequate chemotherapy in the preoperative period, and then I think that should be our target. The tricky bits here, and Jonathan and Phil, feel free to sort of comment. I know the hard part is when you're doing your staging, sometimes the medical oncologist, they're definitely going to want the proof of high-grade tumors. That's where the biopsy becomes really important, because you don't want to understage these patients and have them not be candidates for the therapy they get. And for patients who have node-positive disease, we will give them full dose induction chemotherapy, 6 cycles of cisplatin-based chemotherapy, with the goal of downstaging to the point where we can then take them to the operating room and attempt consolidation. So I think that, again, for those patients who really are high risk, who are at risk for that 50% 5-year mortality, disease-specific mortality risk that Jonathan highlighted earlier, we want to make sure we adequately treat these patients and give them every shot we can. And you're more likely to get cisplatin into a patient who's got 2 kidneys, even if one of them is potentially slightly obstructed by their tumor, that it's a better shot than afterwards.
Actually, you brought up a really important point at the end there, Sarah, which was, some patients come in and they're not candidates for chemotherapy because of poor kidney function up front, because they're obstructed. And so, and that's also part of one of the guideline statements was, that sometimes a stent or a perc tube can be placed to decompress a kidney, and then a patient's GFR will improve, and that may make them then eligible to get neoadjuvant chemotherapy. So that's another, clinical pearl in terms of what to do to help your patients get to appropriate courses and treatment options.
I want to ask you guys a surgical question. I'll tell you, and something that the guideline actually changed my practice in. As we started going through the data for distal ureterectomy and segmental ureterectomy, I started realizing that I didn't like it because of bad anecdotes in my practice and some patients where that outcome didn't work well. But the data is really supportive of distal ureterectomy or segmental ureterectomy for the properly selected patient. Just love to hear your guys' comments on that. And I will say, honestly, it has changed my practice since we put together the data and written this practice and written the guideline.
I am a proponent of keeping kidneys in whenever possible. So in patients who are candidates for distal ureterectomy, that has been something I've tried to prioritize. If they have high risk disease down there, I definitely try to get them chemo first. But then I think that it's basically, if it's below the bifurcation of the commons and you look like you can adequately get an off tension repair, with either a Boari flap or a psoas hitch or whatever else. I mean, I think a lot of patients can be candidates, and you can mobilize the kidney to get a little bit of extra light. The critical point, though, of course, is do you have enough bladder volume, and do you have enough sort of bladder capacity to reconstruct and have it be off tension? Because the worst thing in the world is to have a repair that then goes down, and then you have a big problem and a kidney that's not going to drain well. And you do need to be thinking about sort of recurrence and all of that. So, but in appropriately selected patients, I absolutely think that thinking about distal ureterectomy and low segmental resection is appropriate.
Yeah, I think it's underutilized, and it's something that I usually go to, pretty quickly. I know some people sort of try and go for endoscopic treatment options, even in, bulky low-grade cancers in the distal ureter. And, I tend to go more for distal ureterectomy right off the bat because, you're struggling with the distal ureter, you're doing lasering, you're lasering down there, you get strictures or other things that develop, and it's just a frustration for patients and for us as urologists to deal with that. And so if a patient even has low-grade bulky tumor in the distal ureter, I'll be pretty quick to do a distal ureterectomy and reimplant on those. I would just also say that those patients deserve a node dissection as well. And the data is, we looked at the data very closely as a large meta-analysis in the value and the benefits of node dissection. And I think it shows pretty clearly that there is definitely a benefit to doing node dissection in your patients. And then the templates of dissection have been well described, in the literature. But Phil, maybe you want to. I know you did that lymph node section on the guideline. Maybe you want to go over what the templates are and so forth.
Yeah, I think we know, based on really good data, mapping studies at this country and out of Asia, that the vast majority of the time you're going to find regional adenopathy for these patients. So meaning either periaortic, paracabal, whether it's left or right side, respectively. You will see some crossover, particularly from right-sided tumors into the interaortic cable space, but those patients are often N2 because they will have it in the primary landing zone as well. So the way I rationalize and kind of think about lymph node dissection, which aligns with the guidelines, is you should be removing the paracaval or para-aortic packet in anybody with high-grade upper tract disease. The risk of node-positive disease is significant, and they deserve at least that. Whether you want to cross over and go into the interaortic cable space, I kind of leave to the provider or kind of situation. I don't routinely do it, I would say, because if they are positive there, they're often N2, and there's very little therapeutic benefit to removing those nodes. We have the proper staging. That paracaval or para-aortic packet really should be around the renal hilum and probably down to where the ureter crosses the iliac vessel. For cancers in the distal ureter, it should be a pelvic lymph node dissection, just like we do for urothelial cancer of the bladder. And if you have a mid-ureteral tumor, you got to do both, because the data is pretty strong that they could go into the pelvis or up the para-aortic or paracaval packet. So that's my practice, and I think that aligns with the guidelines as well.
Yeah, I think those are templates that we all kind of followed, to the most part. And typically, it's interesting. One of my colleagues I heard referred to doing a node dissection as kind of a Lay's potato chip approach. You can't just take one, right? So you kind of keep going. So for those of us who do a lot of node dissections, you're kind of constantly chasing, lymph nodes. But I think there is also what the benefit was, shown in terms of the, for patient benefit is. Seems to be a survival benefit for these patients. And in fact, I just, anecdotally, I hate the anecdotal stuff, but I just saw one of my long-term survivors yesterday, a woman who had Lynch syndrome, and she'd gotten neoadjuvant, and I did an FRU on her after neoadjuvant. She had residual low-grade cancer in her renal pelvis, no high-grade cancer, but on the node dissection this is a right side, in her paracables, they were clean. The interaortic cables were clean, but in her retrocables, she had 3 positive lymph nodes, and she didn't go on to get any adjuvant therapy afterwards. That was it. And I saw her back. She's now 12 years out, and I keep following her bladder, which gets into another whole aspect of survivorship and follow up. But I looked in her bladder. Her bladder is completely. She has never recurred in her bladder, and she's never recurred systemically elsewhere. So. I think patients get a therapeutic benefit from node dissection. That's what the data showed, and that's what other, single institutional trials and series have shown.
Yeah, I was interested that when we looked in the data too, that there's a survival benefit in the patients who are N0 and N1.
Yeah.
Right. So you've got a staging and therapeutic benefit there. I think it's a no-brainer. It's really well supported.
And I would just say, the thing about node dissection is everyone talks about the POUT trial, and the patients who had node negative disease actually did better. The ones who had node positive did worse. But you could even make the argument in the POUT trial that for a patient who has node positive disease in the adjuvant setting, they probably should be getting, they have metastatic disease. They probably should be getting full course chemo. And maybe one criticism I would sort of say in that setting is patients maybe should get 6 courses in the setting of metastatic nodal disease. But that's a discussion for another day.
Up to this point, our discussion has been very treatment heavy. Is there ever going to be a patient in whom surveillance or a watchful waiting approach is going to be appropriate?
That's a bit of a challenging question. I think, let's just make the point that urothelial cancer in general, so bladder cancer specifically, but it extends to upper tract, is the most expensive treatment the most expensive cancer that we treat in this country. And upper tract is specifically associated with high degree of financial toxicity and treatment burden for patients, because the surveillance, especially when we keep the kidney in situ, can be very, very intensive, both from a procedural standpoint and a sort of a study scanning and patient visit standpoint. Because not only do we have to surveil the upper tract that's left behind that had the tumor in it, but also the bladder. But there is, I think, a push towards trying to figure out how we can de-intensify therapy and treatment and surveillance burden for patients in whom that's appropriate. So that, again, gets back to our discussion about adequately risk stratifying. And so in the patients who have very low grade, so one of the tricky bits is low grade recurrent tumors. So trying to move towards ablative approaches that don't require as much sort of intensive and invasive follow-up is important. I think one of the things that I think we worked really hard on and putting forth here is a risk-adopted surveillance paradigm that comes after treatment that very much reduces the intensity of follow-up in those patients who do have low-grade favorable low risk favorable tumors. And so again, it's making sure that you're constantly sort of weighing the risks and benefits of the tumor and making sure that you adequately understand you've characterized the tumor in that specific patient. But especially when we're sparing organs, we have to be thoughtful about how we're going to make sure we kind of keep an eye, because we know that this is a field change defect, right? So not only is the area where the actual sort of the tumor at diagnosis, we have to watch that area, but of course their entire urinary tract is at risk for contralateral recurrences as well as intravesical recurrences. So it's a question, again, I think making sure you've risk stratified, and then talk to the patients about sort of what they're about making sure that they're adequately following up.
I tend to be an advocate for all things surveillance in most diseases we manage, but this is a tough one. It's really tough in upper tract urothelial cancer. And I think, the one thing we could all agree on is the patient with the solitary kidney and low-grade tumor, right? Yeah, you can potentially watch that patient or come up with a strategy that keeps them out of the operating room as much as possible and off dialysis. I mean, we all know, in this country, the 5-year mortality for dialysis is about the same as the 5-year mortality for upper tract urothelial cancer. And it's a really challenging conversation to have with patients, but it's a really important one. And to give patients and their families the opportunity to choose, the way they want to live the next, hopefully several years, but you just never know. And it's really hard to say it's surveillance or watchful waiting because we almost always come up with a strategy. All right, we're going to look in 6 months. We're going to take a look again in a year. We may try to de-intensify things, but it's very rarely, see you later, have a nice life, call us, if there's a problem. This is a disease that's tough. Really tough to let go of and really tough to manage if it gets out of our control. So, I always struggle with where the border is with those patients. How far do you let them get away? Is it 3 months? Is it 6 months? Is it a year? And every case is different, but we could all agree that certainly patients, solitary kidneys, patients, end-stage renal disease who can end up on dialysis, that it's worth those conversations.
Because we are running close to our time, I do want to take a minute to discuss, we've talked a bit, recently about surveillance approaches. What exactly does management look like for a patient who has a recurrence?
So when you hear the word surveillance, you think about two different things. One is like the active surveillance where you're not treating and you're following somebody, but the surveillance in this sense means how do you surveil or follow somebody after you've treated them? And there's really two different scenarios. One is in the kidney sparing scenario, right, where you've done an endoscopy, you've gone up in the upper tract, you've treated a tumor with the ureteroscopy, and you've been successful, and you've gone up maybe once or twice after that and found that there's no recurrence. And now how do you follow that patient who has a kidney in place? And then the other is how do you follow a patient who you've done an FRU on and now that kidney's gone and now you're just following the bladder. So it's a lot more simple in that second setting, right? You've taken the kidney out, you're following the bladder, and now you kind of fall into the surveillance pathway of just making sure they don't recur in the bladder, and to some degree they don't recur in the contralateral side, because there's always roughly about a 5% risk of contralateral recurrence in the upper tract. But what patients need to be aware of is that when we wrote this part of the guidelines together and said, you start, and it's like, for certain scenarios in the high risk versus low risk, high risk being high grade cancer where the risk of recurrence is higher and, the intervals are a little bit shorter. Basically, it starts and ends with cystoscopy. It's cystoscopy, checking the bladder, getting cytologies, and then also periodic imaging for the upper tracts. And you can start to spread that out as time goes on. So as a year goes by, 2 years go by, you can be less intensive. You can, you can get to the point with patients, you say, well, you only need to come back, once a year, maybe even once every 2 years when you get to like 10 years out. But the pathway of surveillance goes on. You're right, though. If they do recur, you don't still stay out, once they've relapsed in the bladder or anywhere, you then kind of have to go back to the beginning and say, okay, unfortunately, we got to start back at the beginning again, and we got to start, watching more closely. And also keep in mind, there's crossover here with the bladder cancer guidelines. So if they start to develop bladder cancers, you then, click over to the bladder cancer guidelines and start going from there. But but yeah, those are the challenges. And you'll see within the guidelines we wrote, there are there are management strategies for kidney in place, for kidney sparing strategies. And then there are guidelines for surveillance and follow-up in the setting after nephro-U, and in high risk and low risk scenarios for both.
One thing that Jonathan said that's just so important is, unfortunately, if it comes back, you start all over again with your risk stratification, because you could have a patient who had low grade before and now they have high grade tumor, and so the treatment is going to be based on the tumor that you're dealing with right now. And I think also, sometimes multifocal recurrences can happen, and so you have to take into account sort of where the tumors are, what the bladder what's the status of the bladder, what's the status of the upper tract, and then of course you're looking at kidney function, competing comorbidities, all of those other things to help you guide your sort of intensity of therapy. But you have to sort of reset the clock at that point and start from ground zero.
And one quick point I just make it in the minutes here is that what you're hopefully getting from all of this is that this is not a one and done strategy, for upper tract disease. In our practice, in a place like MSK, where we've got a lot of oncologists and urologists here who deal with oncology, there's really only just one or two guys here that deal with all of this here at our place, and it's me and one of my colleagues. And so it is something that really requires a dedicated person to do this. And some people, first of all, your patients have to be aware of what they're getting into. I think that was also written in our guidelines. Is patients should know up front, what they're getting into with these strategies and what the long term looks like. Patients often kind of deal with some sort of treatment toxicity here, where they're just sort of saying like, does this ever end? And you say, no, this is what we're dealing with. And you need someone who knows what they're doing to do it, who has the skill sets to deal with endoscopy and surgery and all the other things that kind of go with it. And as I like to point out to my fellows every year, I say, look, this is a disease that's more rare than testis cancer. And in testis cancer, there's consolidation of care. If you go to Europe, if you go to the UK, there are only certain centers that are allowed to handle testis cancer. There are some hospitals that aren't even allowed to touch it. They have to, centralize care in different areas. We're dealing with a disease that's even more rare than testis cancer, with a lot of nuances to it as well. So for people who kind of look at this and they say, there's a lot going on here, and I'm not sure I really want to take it on, and then that's perfectly okay. It's fine to find someone either, locally or in your practice, or somebody who's going to really consolidate and deal with these patients, because there's a lot to deal with.
As our time comes to a close, I do once again want to open up the floor. If any of our participants have any questions about anything that our panelists have gone over today, again, please feel free to come on camera and speak up, or use your chat feature as well.
Do we have time for a question?
Yes, please go ahead.
Yeah, Ali Reza Gorefi from USC. I have a question about some differences between the AUN and the EAU guidelines. The first is the role of ureteroscopy. So the EAU guideline consider ureteroscopy as an optional step in the diagnosis of upper tract, but the AUA highly recommend ureteroscopy. This is the first question. And the second one is this new risk stratification. Is there any data to support this? Because I couldn't find anything in the supplement or in the references. Or it was just based on the panel's consensus to come up with this new risk stratification? Thank you.
We'll do the second one first, Ali. Great questions. There is data, and there's I don't know how many page document that I'm not sure if it's published yet, but it should be available, is the data behind the guideline. And so a big systematic review is done by an evidence-based practice team around the country. And that risk stratification does predict stage 2 or higher disease. That was the objective criteria for risk. And that's what we didn't want to happen. And listen, we love our colleagues in the EAU and we love their guideline. But one of the things is high risk for what in the EAU guideline? It's not entirely clear what high risk is predicting. So we wanted to be very explicit about what high risk predicts. It's high risk for invasive disease. And then we could say, all right, if you have an invasive disease, we think you should get chemotherapy. If you have invasive disease, we think you should do this. But that was kind of the basis for that stratification. So yeah, we're hoping people will pick this apart And the next iteration of this, there will be a better risk stratification because smart people around the world are going to say, okay, let's get even tighter on this risk stratification, or let's knock it down and build something else. But hopefully now more data will come out either supporting or refuting that. But that's the best data we have so far.
And I'll just point that the one thing I hear about people ask me all the time is size. Why isn't size in there? And that's because when we looked in the data to try and find out, where a size fit, there were several problems with size. One is that there is no objective criteria for selecting tumor size. Even on CT scan or MRI, it doesn't match up with final pathology. So having preclinical size criteria was very hard, and it turned out that it didn't even really. When you looked at it, it was not an independent predictor. In other words, when you factored in obstruction or multifocality or sessile versus papillary architecture, then size fell out because those were more important predictors than size itself. But yeah, to echo Phil's point, and this was heavily data driven, and there actually is a big supplement that if you can't, it's not in the Journal of Urology. If you go to the Journal of Urology, that came out that the supplement's not there. It's in the actual AUA guideline supplement. If you go on the AUA website, it's there.
And then Alireza, to your first question. So the reason why ureteroscopy, why we came down so strongly in recommending that as part of the initial diagnostic evaluation is because a lot of the features that were independently predicted with the risk of invasive upper tract urothelial carcinoma, which again was the outcome we arrived at as being the most critical in terms of risk stratifying. Papillary versus sessile nature, the multifocality, a lot of those features can't necessarily accurately be predicted based on cross-sectional imaging alone. And so when feasible, upper tract ureteroscopy is kind of critical in terms of identifying the burden of disease and the nature of the disease, which is important in terms of helping us to understand the risk that this patient's got T2 or greater disease, which then guides our treatment recommendations. So that's why we came down on that as a critical component of the evaluation.
Thank you.
All right. Well, thank you, everyone. We appreciate your time and joining us for today's discussion. Again, as our panelists mentioned, the full guideline, the unabridged version of the guideline is available on the AUA website at auanet.org. So please feel free to use that guideline. There are additional publications as well available through the Journal of Urology and other AUA publications. Thank you again for your time, and we hope to speak to you again soon.